Okay.
Siva?
Yes, sir. Kindly bear with us because of the internet connectivity issues.
Now I would like to invite our guest of honor today. Dr. doesn't need any introduction. Everybody knows everything about the life of the Ravi Shankar sir. As ISA Pondicherryans, we are lucky to have him as our mentor in our ISA Pondicherry. Everybody knows about the anesthesia part of the Ravi Shankar sir, but as the ISA member of Pondicherry, he is the one who is responsible for bringing this ISA Pondicherry into the national level. He is the one who started the first ISA state conference, and under his leadership, we have done so many state conferences, South Zone conferences, national and international conferences also. He's always the guiding force for us. He is the Dronacharya for us. So we have learned so many from his lectures and his workshop. We are all happy or proud students of Ravi Shankar sir. We are happy to have you as our guest of honor. We would like you to say a few words and bless us for this conference, sir. So Ravi Shankar sir, please.
Yeah, thank you, Dr. Ranjan. I mean, it's nice to hear that I have been instrumental in doing this. Yes, I think we started in 1978. We got it converted into a state branch quite late, about 10 years back.
Yes.
And I'm quite happy that the society and the state branch is doing very well, especially in this time, the last 1 year. I should congratulate Ranjan and Nagalakshmi for taking it forward, for conducting this, not giving it up, but conducting all of them virtually on a platform. I should say it is quite a show. And because maybe this was the first time that is being done. Still, the Pondicherry branch took the initiative early enough and then was conducting these meetings in the month of April and May. And I'm happy that, and I'm also thankful to the society members and all the members assembled here for giving me this honor to be the inauguration. And it's my pleasure to say that and say it is open. Thank you very much.
Thank you. For the conference, Balavik, sir, please.
Muralidhar Joshi, Secretary Dr. Naveen Malhotra, the galaxy of esteemed leaders of ISA who are present here. I deem it a great privilege to be a part of this meeting and the inaugural function. And I'm sure with all the efforts that you have taken to bring in the best of the topics and very good speakers from across the country, it would be a great success. Every meeting imparts and enriches the delegate who is attending with few facts, which if he puts into act in incorporating it into his clinical practice, will make a difference in the life of innumerable number of patients who completely depend on us and surrender to us when they come into surgery. So meeting like this helps us to learn the new things, updates, and the possible issues and complications that have happened over a period of time. So this enrichment has been made possible by the ISA Pondicherry to all the delegates, and I'm sure the deliberations will be very, very useful and meaningful to all concerned. Thanking you for the opportunity. Thanks, Ranjan.
Thank you so much, sir. I'll request our ISA National Academic Coordinator, my teacher in MBBS, Dr. Balabhaskar sir, to say a few words and bless us for the conference.
Good evening to Dr. Muralidhar Joshi, President ISA, Dr. Naveen, our Secretary. Then we have got Dr. Venkatagiri, our President-elect, and our colleague in the GC, Dr. Bala Venkat. Then Dr. Ranjan, the President of the Pondi branch, and Dr. Nagalakshmi, the Secretary. And I got, of course, senior most academician, a towering personality by himself, Dr. Ravi Shankar sir, and rest of my colleagues. As we have been discussing, it is not a pandemic. It has been a useful side effect. It has become pan-academic. So all of us have been somehow been there meeting for academic purposes in the pandemic. So that has been the advantage. So very happy to note that the academic activity is continuing in the ISA Puducherry branch. So wishes from the academic committee from ISA National for a successful program. Thank you very much, and long live ISA. Thank you.
Thank you, sir. Thank you so much, sir. Now I request our dynamic leader, ISA Secretary, Dr. Naveen Malhotra, sir, to say a few words. Actually, he is one person who is always both for the academic as well as for the benefit of the society. From the day lockdown was announced, Dr. Naveen Malhotra, sir, he is on his toes to increase for the patient health as well as for the academic activity. Both are going simultaneously without a hitch. We are very thankful to you, sir. We would like to, we would like you to have a few words and bless us for the conference, sir. Dr. Naveen, sir.
Thank you, Dr. Ranjan. Respected Dr. Muralidhar Joshi, President ISA National. A very respectable teacher, Dr. M. Ravi Shankar, sir. Now currently Director E-Learning and GMCRI Puducherry. Dr. Venkatagiri, President-elect, ISA National. Dr. S. Balabhaskar, Chairman, ISA Academic Committee. Dear Dr. Bala Venkat Subramaniam, our PC member. Presiding Officer, Dr. Ranjan, President of ISA Puducherry branch, and Dr. P. Nagalakshmi, a very humble Secretary of ISA Puducherry branch, and the Treasurer and the Organizing Secretary of today's conference, Dr. S. Sivakumar, and other senior members present here, Dr. Ramachandran T.R., Dr. Prasanna Bidkar, Dr. Raj Shadanan, Dr. Sandeep Mishra, Dr. Arun Kumar, and others. Really, it's very nice to be here in the inaugural ceremony of the 11th ISACON Pondicherry. Yes, I endorse Dr. Ranjan's view that we were supposed to be in Pondicherry enjoying the scientific feast as well as other activities with the South Zone Conference somewhere in August, September 2020. But due to this pandemic, we are not meeting physically, but the ISA academic activities are going on in full swing. And I'm happy to share with you that since November onwards to almost February end, all the ISA state branches are doing academic activities either in the forms of the state conference or other academic activities almost every weekend, and that is lined up. And looking at the scientific program of this particular conference, I'm really very happy that there are excellent topics, very nice speakers, and I'm very sure that the delegates have a scientific feast over the next 1.5 days. And as a part of the ISA National support to the academic activities, we are promoting ISA academic activities in all fronts, including the financial aid. As I've discussed with Dr. Nagalakshmi also, ISA National will be partly supporting and funding this conference also, like any other state conference. I'm very sure that the delegates will have a very good time over the next 1.5 days, and I look forward to interacting with you all tomorrow also. Thank you very much. Long live ISA. Jai Hind.
Thank you, sir. Thank you so much.
Thanks so much.
Now, ever smiling, our President-elect, Dr. Venkatagiri, sir, he is with us from so many years. He was our secretary, previously was national secretary. That time, he was very supportive to Pondicherry. Now he is the President-elect. We expect the same support from him throughout. Sir, please, we would like to hear a few words from you and your blessings, sir. Venkatagiri, sir.
President Dr. Ranjan, National President Dr. Joshi, guest of honor, Chief Guest Ravi Shankar sir, all dignitaries, my colleagues in GC, past President Bala Bhaskar, and all dignitaries of Pondicherry. If I name that, the list is long and I will talk less. So good evening to you all. Namaste. As Ranjan told, my associate with Pondi is since a long time, since I was GC member. I was regular in attending the conferences in Puducherry. Remember that overnight there was rain and all when we had a conference in Jipmer and all. We had run and all. And afterwards, it was a nice experience coming to Puducherry. But this time we also wanted to come to Puducherry and attend the South Zone. But this pandemic made us different.
Please,
And
we would like to hear
definitely next year we will come there and we will enjoy. We are hosting the same zone conference next year. Dr. Ranjan is the Pondicherry next year.
Yes, sir.
And they, in a way that for me, this virtual conference is better because I can attend at least some CMEs. But wherever it was a real physical conference, I don't think I have attended any CMEs in the last maybe 10 years, because every time there is one or the other business meeting or meeting others and other office bearers and all. We never had, except maybe when we are chairing a session. Otherwise, we never had the opportunity to attend the meetings. So for people like me, it is a blessing in disguise. Maybe many other IS officials. I wish all the best and good scientific deliberations and all. And since a long time, I'm telling that Puducherry people, please host one zonal conference, zonal PG CME. I was telling during my period, but if that, at least next year you will do that one CME, PG CME or zonal CME next year and do that because I was telling it a long time. All the best and see you in the physical conference next year in Puducherry.
Thank you, sir. Thank you so much. Now it's my honor to invite our chief guest, Dr. Muralidhar Joshi, our ISA president. I think he doesn't require any introduction. I just got to know that he is my senior in Bellary. It was icing on the cake, and he has got many firsts to his name. Just to name few, he was the first one to introduce epiduroscopy in South India, and he was the first one to start so many fellowship in South India, and he has won a lot of awards. More than that, he was a guiding force to us in this pandemic 2020. Along his ISA, under his leadership and under his committee membership, we were able to sail through this pandemic as an anesthesiologist by various guidelines which are formed along with Dr. Naveen Malhotra. It was very helpful for us. Now I request Dr. Muralidhar Joshi sir to say a few words. Sir, please.
Good evening, everyone. Respected President of Puducherry ISA, Dr. Ranjan, and who happens to be probably my colleague from my medical college, my alma mater.
Yes.
And nice, Dr. Ranjan, seeing you here. And Honorary Secretary of ISA Puducherry branch, Dr. P. Nagalakshmi, the Honorary Secretary of today's event of the Puducherry ISA conference, Dr. S. Shivakumar, and of course, thank you so much for inviting all of us here. And my special thanks to the guest of honor, Professor Ravi Shankar sir, Dean, and I don't know what Dean, Director, whatever name we give, and he's there. He fits into everything. And so, sir, you have been like a teaching guide for all of us and all. Hats off to all of you and all those things. Before I express my thoughts and views, first of all, I would like to salute all the COVID warriors whom we lost in last probably 1 year, and probably we don't know how long the pandemic might last. Maybe another 1 more year we might lose. But yes, question here is we have to move on and get on with life, and we're not supposed to stop the journey. That's about, see, when the going get tough, the toughs get going. So that's what the ISA spirit is. So let's not forget, when the going get tough, the toughs get going, and we are ISA, and we are going to do it, and all the time, every time. So there is no doubt about that, what we're going to do. And due respect all the COVID warriors whom we lost and all the seniors and whomsoever has worked and all the youngsters and all. And the salutation to our President like Dr. Venkat Giri, Chairman of Academic Committee Dr. Bala Bhaskar, Honorary Secretary Dr. Naveen Malhotra, our governing council members from like in the southern part of the India, Dr. Ganesh Prabhu, Dr. Bala Venkat, Dr. Chintala Krishnan, and all the senior faculty members who are presenting their all views and thoughts, and of course the delegates. Without them, no event can go on. So basically, I should say, like in every challenge comes with an opportunity. You should understand that particular thing. let's not forget. Then the cell phone came and all those things, people talked about why the cell phone came and all those things and all. Now, probably, it's like I live in Hyderabad, which is a part of Telangana, which is the landlocked territory. We don't have access to any sea. I think people from Pondicherry have access to sea, and Dr. Venkat is sitting there smiling, and the entire western coast belongs to him only, the lower part, and then somebody, Dr. Balavenkatam, or like, Ganesh Prabhu, they have the eastern coast on their control. And all this, the question here is the fishermen who go on the high seas, fishermen who go on the high seas, when suddenly you go there, suddenly see some pandemic, some cyclone getting created, some depression on Bay of Bengal and all, this notorious place and all. But suddenly you have to send an alert to the fisherman to come back to the shore. And this is where the floating, so what is the floating, whatever I would like to say, that the floating towers on different islands or land masses, what the government of India has been putting the towers for the cell signals. The mobile, what the fisherman will be carrying, he knows, look, it looks like a cyclone is going to form in the next 3 days, please come back to the shore. So question here is every challenge, and okay, fine, you may not like mobile from your point of view, fine, no problem, but I like it because my countrymen, they are safe, they can reach back to the mainland, like in the next 3 days, it's going to hit, say, for example, the coast at Mahabalipuram, or maybe I can say, like, it might hit Chennai, or it might hit Pondicherry, something like that I can say. So I look at every challenge, I don't look mobile phone as something wrong, as like, everything is as good as the user. Everything is as good as the user. If you know how to handle the web situation, have web control and all, definitely you can help everyone. There's nothing wrong about it. But if you don't know how to use it, you can always misuse it. Use and misuse is not a big deal about that one. The question here is, it's an opportunity. And if you ask me, yes, why did you take this particular 1 year? Yes, we had lost a lot of our own, I should say, like senior faculty members, youngsters and all. But look at the opportunity what it has created. The web platform probably we never explored earlier. We were doing it a little bit here and there and all those things. But now, yes, having said that, let's not get depressed that we are not met each other personally or physically. But let's look at the opportunity what it has given. We are able to meet virtually. We are able to communicate to each other. We are able to talk to each other. And as Dr. Venkat Giri rightly expressed, like he's able to attend more scientific programs these days. And that's a take a message from this particular today's event. And you have lined up fantastic faculty, and I'm sure Pondi will do a great job. There's no doubt about that. But before I end, I have a small request to Puducherry ISA. I hope you people support us in this particular aspect. We are launching national registry from national body, national registry and all. I do understand, Puducherry is a medical hub. When I last visited, there were 6 medical colleges. Ranjan, has the number increased?
Yes,
to another 6?
Yes,
plus 6?
Yes, sir. We have one more government medical college now. In Indira Gandhi Medical College.
And I have a lovely memory of Puducherry airport, reason being that's the only airport in entire India where auto can come inside. In no other airport, autos are allowed. So I'm happy about it. So let's be economical, let's be comfortable. So I love Puducherry for simple reason because it's simply high thinking. The principle floats in Puducherry, nowhere else. Yes. Let's start from there. So I love Puducherry for that particular thing. I might say Pondi, somebody Puducherry, but I still like it Puducherry. The way it is and all, I really love it and I really like it and all. But I am telling you that we're looking at national history, and Dr. Venkat Giri also a big task as coming as the next president when he has to take the charge and all. But national history is very important because all the time we are quoting the information from XYZ countries in the Western world. Please understand it's important. But the national body is working hard to maintain secrecy and all those things. Your information, your portal is safe and it will be yours only. We don't want to touch that particular one. Only we want to like how many trauma cases you did that year. That's the only reason being we can provide our anesthesiologists in a better way at national level. When you sit across the chair of the government of India, we need this information. How many sections you did, that's all. Or how many trauma you did, or how many open surgeries you did, how many transplants you did. This because it becomes easier because national body has 35,000 people and all. If you don't go to the meeting without having this information, we'll be getting sorry figure, and some person over there will say, okay, we'll talk about it next time. Please help us so that we can help you much better. Thank you, everybody. Long live ISA. Jai Hind. That's it.
Thank you so much, sir. Thank you so much. I'm sure my godfather, my mentor, T.R. Ramchandra, will be happy with this speech. He is telling us to do this work, maintain this national registry since 2005. He is telling, please maintain. India, we are lacking in that area. We should do that, sir. We
are on the job. We are on the job. Just because plan is slowed down, but now content is ready. We are about to launch it. As simple as that, Ranjit. Thank you, everyone.
Thank you so much for your encouraging words, sir. Now I'll request our organizing secretary, Sivakumar, sir, Dr. S. Sivakumar, to say a vote of thanks.
Am I audible, sir?
Yes.
A very good evening to respected and esteemed dignitaries, faculties and delegates. It is indeed a great honor and privilege to propose a vote of thanks on this occasion. Let me start by thanking Almighty God for making this function a grand success. First and foremost, I thank our ISA President, Dr. Muralidhar Joshi, sir, for gracing this function in spite of his busy schedule. Also, I express my sincere gratitude and heartfelt thanks to our guest of honor, Dr. Ravi Shankar, sir, for accepting our invitation in a very short notice. I also thank ISA National Governing Council members, Dr. Bala Venkata sir, Dr. Ganesh Prabhu, sir, and Dr. Chintala Krishnan, sir, and Dr. Bala Bhaskar, Chairman, Academic Committee, ISA National, Dr. Naveen Malhotra, Secretary, ISA National, and Dr. Venkatagiri, President-elect, ISA National, for gracing this occasion in spite of the busy schedules and for their constant support and guidance. I also extend my gratitude to our Chairman, Mr. M. Philip, our Director Principal, Dr. Renu Chibai Vagis, and our Head of the Department, Dr. Sajjan, for their constant support and their guidance. I like to extend my thanks to Dr. Ranjan, ISA Puducherry, Dr. Nagalakshmi, Secretary ISA Pondicherry, and working committee members, executive committee members, and all ISA members of the Puducherry, without whom this extend my sincere thanks to all my colleagues, senior residents, and my postgraduates for their untiring work for making this conference a fruitful one. I also thank the EDB department for the technical very hall for conducting this virtual conference. I thank Dr. Rahul Choudhury from Anesthesia TV for providing us the online platform for telecasting this conference. For the timely help in conducting the conference. Last but not the least, I thank Mr. Praveen, our web designer for ISACON Pondicherry 2020, without whom this virtual conference wouldn't be possible. If I left anyone from thanking, it's due to lack of time and it's not intentional. Once again, I thank everyone for gracing this function. Long live ISA and Jai Hind. Thank you, sir.
Thank you so much, sir. Thank you so much. We will conclude the program with the national anthem. Dr. Nagalakshmi, is it possible to share national anthem? I would like everybody either to switch off the video stand or switch off the video before doing this.
Sure.
गुजरात मराठा द्राविड उत्कल हिमाचल यमुना उच्छल जलधि तरंगा तव शुभ नामे जागे तव सुप्रभात मागे गाहे तव जय गाथा गण गण मंगलदायक जय हे भारत जय Thank you.
Thank you all. Thank you, dignitaries. Thank you all. Thank you for your support and encouraging words. We will we'll start with our academic session. Thank you so much. We would request you to continue, in your presence in the academic session. But I know you people are busy. If you are busy, please bless us for the success of this conference. Thank you very much.
Thank you, Dr. Benjamin. Thanks a lot. Thanks to your team.
Thank you so much, sir.
Thank you. From the Pondiccherry ISA. Thank you so much.
Thank you, sir.
We will start with our academic session. Dr. Nagalakshmi, my audio is okay. My internet connection is a little poor. Siva, it's okay?
Yes, sir. It's fine, sir. Fine, sir.
Okay. So today we have planned evening session with the super specialty session, and we couldn't find anybody better than Dr. Ashok Shankar Bade to chair this session. Probably he is one of the most experienced person in this super specialty area. He does everything which concerns with the super specialty. Very active member of the ISA, always into the teaching. He is my neighbor. Whenever we meet, we always do talk about the academic session. Moreover, he's a national badminton champion, current national badminton champion also. So it is my honor and pleasure to invite Dr. Bade sir, and the next person who will be chairing the session is Dr. Satyan Parida. Probably he is stuck in the OT. He will be joining us in a few minutes.
Ranjan, I've joined. Ranjan, I'm back here.
Oh, okay. Hi. Dr. Satyan, he is the additional professor. Basically, he takes care of the cardiothoracic anesthesia in JIPMER. He's trained in he has a fellowship in cardiothoracic anesthesia and a very good academician. He's a very active member of the ISA, always into the academic activities. So we welcome both Bade sir as well as Dr. Satyan to chair this session. The first lecture will be by my mentor, my godfather, whatever you can call it as, Dr. T.R. Ramchandran will be doing this lecture. I'll request Bade sir to introduce Dr. T.R. Ramchandran sir. Nagalakshmi, can you put the PowerPoint of
Yes, sir. Yes, sir.
TRSS?
Yes, sir. Yes.
Bade sir can introduce. So, Bade sir, probably, sir is already started.
Hello.
Yes, sir.
Good evening. I hope Dr. Ranjan and the Secretary, Dr. Nagalakshmi, for inviting me to chair a session of three very, very prominent speakers in a different of anesthesia. Dr. Professor T.R. Ramchandran, who is a brigadier from the army, and he is well known for his cardiac anesthesia and is very, very active member of a Cardiac Anesthesia Society of India. As he is also very, very active cyclist. And all of you must be knowing that he used to cycle quite kilometers and to keep his health. So with this introduction, I request Dr. Ramchandran, sir, to continue his first talk.
Thank you, Ashok. It's a pleasure seeing you there as and for your kind words. So I'm indeed honored to be part of the ISACON Pondicherry 2020, and I'm most thankful to Ranjan and his team to invite me and be part of this conference. So I'm sure it would be a great success. And I would warm greetings to all the dignitaries who are going to be part of this session on super specialty, especially Raj as well as the Prasanna, who are good friends of mine. So without much ado, I would start my talk. We'll be talking about the acyanotic congenital heart disease, which can present for non-cardiac surgery. Now we are going to present only few of them, like atrial septal defect, the ventricular septal defect, and the patent ductus arteriosus. Atrial septal defect, we know that there is an opening in the atrial septum, and one of the most common is secondum ASD. Of course, we have the sinus venosus ASD, the unroofed coronary sinus, the common atrium, the persistent foramen ovale, and the primum, septum primum ASD. Now, this is the schematic showing the ASD and the left-right shunt. There is a step-up of oxygenation in the right atrium and the right ventricle, as well as in the pulmonary artery. There is increased blood flow going through the pulmonary circulation, so that as the child becomes older, then there will be development of pulmonary hypertension. This is the 2D echo showing the ASD. Now, this is the 3D echo of an ASD of a small child, a large ASD, and this is also of another patient. Now, this is the sinus venosus type of ASD, which will be associated with the PAPVC, that is partial anomalous pulmonary venous connection. That is, both the right upper pulmonary vein and the lower pulmonary vein will be joining the superior vena cava, and there is a left to right shunt with the step up in oxygenation. Now, this is the unroofed coronary sinus. The point to note here, the coronary sinus, you will have the left SPC, which will be joining the coronary sinus, and hence, so we should be very careful in not, tying off this LSVC. So we should be understand that this is what is producing the left to right shunt. Now, this is the ECG of a 3-year-old boy with a large ASD. It shows that there is a right ventricular hypertrophy as well as right atrial enlargement. Now, this is the ECG of a 37-year-old woman with a large ASD showing atrial fibrillation. Now, the hemodynamics, we know that in ASD, there is a left to right shunt, ventricle and the pulmonary artery. Eventually, pulmonary hypertension develops and pulmonary vascular obstruction, leading to Eisenmenger's reaction. Then there is a reversal of the shunt, it will be a right to left shunt, and systemic desaturation and cyanosis develops. Now, this is the schematic representation of Eisenmenger's reaction, where you can see that there is a right ventricular hypertrophy. The pressure within the right ventricle is about 100/80, and in the pulmonary artery is about 100/40. So there is very severe pulmonary hypertension, and there is a reversal of the shunt from right to left, and it produces systemic desaturation, and the patient will be presenting with cyanosis. And this is the X-ray chest of a patient with Eisenmenger's reaction. You can see that there is the cardiomegaly, the prominent main pulmonary artery. See, when you look at the pulmonary artery, there is the peripheral pruning is there because of the severe pulmonary hypertension. Now, this is the CT scan. It's showing again a large right ventricle with a right to left shunt. Now, this is the 3D CT of the heart, where it shows a large right atrium, the right ventricle, and the main pulmonary artery with the. So the symptoms, we know that a large ASD, the child would present with fatigue, frequent upper respiratory infection, failure to thrive, and breathlessness on exertion. The moment the Eisenmenger's reaction sets in, the cyanosis, that is polycythemia, it can produce brain abscess, syncopal attack, hemoptysis, and right heart failure. The most common arrhythmia that is seen in the elderly patient would be an atrial fibrillation. An older patient with untreated ASD could also develop a mitral valve prolapse with mitral regurgitation as well as the tricuspid regurgitation. Now, symptoms, or how does a child develop? When we examine, there will be a parasternal heave. There will be the second heart zone will be split. There will be an ejection systolic murmur. A large ASD can also give rise to a diastolic rumble over the tricuspid area. Whose chest X-ray would show cardiomegaly. ECG will show a right axis deviation, the right ventricular hypertrophy, and sometimes a partial right bundle branch block and a prolongation of the PR interval. Now, the echocardiogram is all that is required to diagnose ASD. But what we need to evaluate the pulmonary venous connection, especially where there is a sinus venosus ASD, we need to estimate the pulmonary artery pressure, evaluate the right ventricular function. Now, we know that cardiac cath is not essential, but if we are thinking of a device closure, then cardiac cath and a coronary angiogram is absolute must. In the older patients with unrepaired ASD, before surgery, we should do a cardiac cath, especially if it is, even if it is a device closure, a cardiac cath is a must. Now, the natural history of ASD, we know that there could be a spontaneous closure before the age of 1 year, a large defect. If it remains unrepaired, it is seen that above the age of 20 years, it can develop into a Eisenmenger's reaction. Then there could be atrial arrhythmias, mitral valve prolapse, there could be RV dysfunction, and there could be cerebrovascular complication due to paradoxical. Then, of course, you can have the Swiss cheese type of VSD, which is a multiple muscular VSD. Now, this schematic, this number 1 is the perimembranous VSD. Number 2, the subarterial VSD, doubly committed. It be committed towards the pulmonary artery as well as the aorta. Then the number 3 is the outlet VSD. Number 4 is the inlet VSD. 5 and 6 are the muscular VSD. Now, this is the perimembranous VSD with a large left to right shunt. There will be biventricular hypertrophy will be there. There will be the step up in oxygenation in the right ventricle as well as in the pulmonary artery. Now, here is the specimen of a heart where you can see the perimembranous VSD. Now, this again is the visualization of the perimembranous VSD. Now, this is the subarterial VSD, which is doubly committed, that is doubly committed juxta-arterial VSD and subpulmonic VSD. Okay. Now, this is a large defect in the muscular septum, which is producing a left to right shunt. Now, this is a multiple VSD, that is the Swiss cheese type of VSD. Multiple VSD is there in the muscular septum near the apex of the heart. Now, this is the Swiss cheese, which is on the right side, and on the left side is the septum. Now, if this is the ECG of a child with VSD with moderate pulmonary hypertension, so there is it shows a biventricular hypertrophy. Now, we know that since there is a left to right shunt, there will be increased blood supply in the pulmonary circulation, and ultimately the Eisenmenger's reaction can occur, and there will be RV hypertrophy. You look at the pressure in the RV is 100/8, so that the RV pressure is equal to the LV pressure, so there will be reversal of the shunt. Of course, the PA pressure is also very high, so there will be a reversal of shunt, that is right to left, and there will be systemic desaturation. So there will be cyanosis. When the moment the child develops cyanosis, it becomes inoperable. Okay, so this is the X-ray of an infant with a large heart. This is due to a VSD with a large shunt. Now, this is after the Eisenmenger's reaction has developed. This is a cardiomegaly with a main pulmonary artery is so much enlarged, and you see the pulmonary artery, only the proximal pulmonary artery segments can be seen. The peripheral cannot be seen, so it is the severe pulmonary hypertension. So it's called the peripheral pruning of the pulmonary artery, which is very nicely seen in this X-ray. Now, the symptoms, a small VSD does not cause much symptoms. A large VSD, congestive heart failure, poor or small frequent feeding, there will be failure to thrive, there will be tachypnea, frequent respiratory infections, fatigue, and dyspnea on exertion. As the pulmonary arterial pressure increases, the symptoms will gradually improve in these children. But the moment the Eisenmenger's reaction sets in, well, the child develops cyanosis and severe symptoms. Now, when you examine, there will be a palpable thrill, there will be a loud holosystolic murmur. Infants with a large VSD and severe pulmonary hypertension might have just a loud diastolic murmur instead of a systolic murmur. And as the pressure within the pulmonary artery increases, then the second heart sound becomes loud and single. Now, ECG, a small VSD will not have any changes in these ECG. A large VSD, there will be a left to right shunt, so LVH is there, still the patient is operable. A large VSD with severe pulmonary hypertension will have a biventricular hypertrophy, but it is still operable. But the moment Eisenmenger's reaction has occurred, there is a right ventricular hypertrophy with right axis deviation, and then it becomes inoperable. Now, echo is usually done to diagnose the VSD. Now, what's the natural cause? The child will come to you with frequent respiratory infection. The child can also develop aortic valve prolapse, especially with a subarterial VSD, and it can have an aortic regurgitation. If the child has developed pulmonary hypertension, severe pulmonary hypertension, there could be a reversal of the shunt. Infective endocarditis is seen, especially in small VSD with a jet lesion on the right ventricle. So there could be, the child will present with infective endocarditis. RVO2 obstruction and double chambered right ventricle can also be developing. Then, of course, rarely there will be a Gerbeaud defect where there is a left ventricular to RA shunt. Okay, what are the indications for surgery? Subarterial VSD, large muscular VSD, large perimembranous VSD, VSD with RVO2 obstruction, and perimembranous VSD with LV-RA shunt. So these are all the indications for surgery in patients with VSD. Now the anesthetic goal here, as I said earlier, both for cardiac and non-cardiac surgery, the goals remain the same. That is, you maintain the heart rate, contractility, preload to maintain the cardiac output. Avoid decreases in the PVR, because the moment the PVR reduces, what will happen? There will be the left to right shunt will increase. If there is an increase in the PVR, it will produce a right to left shunt, especially when the pressures in the RV and the LV are almost equal. Now, patients with right to left shunt, remember, it will be very difficult to maintain the PVR. So we need to maintain the PVR in patients with right to left shunt and maintain the SVR or even increase the SVR so that you can reduce the magnitude of the right to left shunt. So these are the maneuvers that we need to do during the anesthetic. Now, infants and children without congestive heart failure, inhalation induction is well tolerated. There's no problem at all. Infants with congestive heart failure, you need to induce with IV induction with fentanyl and sufentanil so that you can maintain the hemodynamic stability. Now, patients with reactive pulmonary hypertension, it is better we use a high opioid technique so that it blunts the PVR increases. Now, IM ketamine can be used for placement of IV access in these children. Non-cardiac surgery, remember, repaired VSD can have a residual shunt. They can come with ventricular dysfunction. They can come with pulmonary hypertension, dysarrhythmias, and they could also have the conduction defect like right bundle branch block or even complete heart block after a repair. So we need to be aware of that. Now, this is the PDA. Now, PDA, we know that there is a connection. There is actually a PDA in the fetus. Now, that persists and there is a connection between the descending aorta and the pulmonary artery. Because of this connection, in fetus, the flow is from right to left, but the moment the child is born, the flow is between left to right shunt is there. That is from the aorta into the pulmonary artery. The incidence is about 5 to 10% and female preponderance is there. This is the schematic representation where you see the PDA now from the descending aorta to the pulmonary artery with an increased flow in the pulmonary circulation. That is the QP by QS will be 2:1 or 3:1 depending upon the size of the PDA. Now, a large PDA with pulmonary hypertension and pulmonary vascular obstruction can go into Eisenmanger's reaction. That means you see there is a right ventricular hypertrophy and there will be a reversal of shunt. Now the flow would be from the pulmonary artery. You see the pressure, the pulmonary artery pressure is 100/40. So from the pulmonary artery into the descending aorta. So that will be the right to left shunt, and there will be, the child will present with differential cyanosis. That means there will be cyanosis in the toes of the feet and no cyanosis in the upper part of the body. Now, a small PDA, there will be no symptoms. A large PDA, there will be frequent respiratory infection, poor growth, symptoms of heart failure will be there. As the pulmonary arterial pressure increases, the symptoms of heart failure will improve. Eisenmanger's reaction, there will be differential cyanosis. Premature children with low birth weight with a large PDA can present with heart failure, ARDS, and necrotizing enterocolitis. So this is a very dangerous combination. Usually you lose the child. Now, usually there is a high-pitched continuous murmur. A large PDA, there could be increased pulse pressure and bounding pulse. X-ray chest, there will be cardiomegaly, main pulmonary artery. ECG, small PDA, there will be normal. A large PDA with a large left to right shunt, there will be left ventricular hypertrophy. A large PDA with moderate pulmonary hypertension, there will be biventricular hypertrophy, and as well as in adult. So these are the different devices which are used for device closure. Now, anesthetic goal. Again, all patients with left to right shunt, you need to maintain the heart rate. You need to maintain the contractility and maintain the preload. Don't overload the patient. Okay, so that you can maintain the cardiac output. Avoid again decrease in the PVR, increase in the PVR. They all left to right shunt, you should look after the bubble. No air bubble should be there in the IV lines. And premature with heart failure do not tolerate inhalation induction. So you should give fentanyl, midazolam with low concentration of sevoflurane might be well tolerated. Older children with pulmonary occlusive disease, inhalation induction, IV access, rocuronium and fentanyl can be used. So this is the anesthetic management. There is in the OR is possible even in non-cardiac surgery. Now remember, if a child with a repaired PDA comes to us, there could be recurrent laryngeal nerve injury in these patients. Okay, there could be pulmonary hypertension. Also, there will be ventricular dysfunction. Now there is, okay, we'll have the common ones are the ASD secondum, repaired VSD, sinus venosus VSD, pulmonary valvular stenosis, and pulmonary ventricular dysfunction, arrhythmias, conduction defects, residual shunts, valvular lesions, regurgitation or stenosis, and aneurysm formation. All these are the long-term. What are the non-cardiac sequelae of long-term consequences of congenital heart disease? Are secondary erythrocytosis, cholelithiasis, nephrolithiasis, developmental abnormalities, seizures due to previous thromboembolic episodes, hearing or visual loss, restrictive or obstructive lung disease. Present for non-cardiac surgery. Some of the patients would not have had the surgery. Some patients would have had palliative surgery. Some patients would have had complete anatomical repair. But what we need to understand that all patients of congenital heart disease, when they present in adult,
giving this a thorough assessment of the fitness of surgery is essential in order to ensure that none of these patients are denied a potentially life-threatening treatment, life-saving treatment, sorry. So this is my conclusion slide. So the surgeon can change the incision type. He can change the extent of resection. And these are two things which can make a difference in the post-op outcome. We can give external analgesia. We have different options now. We can make a difference in ALI. And the prehabilitation can improve the cardiopulmonary reserve. And with everything together, we can have a very good post-op FEV1 on day 1 and day 6. That's the immediate perioperative period. And together, all these changes can improve the outcome. So I think I have convinced that with careful preoperative preparation and with our current knowledge and surgical techniques, we can offer this curative treatment to a much more larger population. Thank you.
Yeah, thank you, Dr. Raj. You did, in fact, manage to convince all of us about, how we should be going about approaching these cases. I'm sure a lot of questions were answered on the way. If you still have some questions, I would request you to pass on those questions for the larger audience out there. I would request you to pass on those questions to the coordinating team, and they will direct those questions to us. And most of the questions can be discussed at the end of this session, which will be at the end of the next lecture. So I invite Dr. Ranjan to roll the program on and get on with the next one.
Nagalakshmi, next slide is ready. Nagalakshmi. Hello. Nagalakshmi?
Yes, sir, I'm there, sir.
Can you, next slide, CV?
Yes, sir, yes, sir. Yes, sir.
Now I request Bade sir to introduce the next speaker, very close friend of us, Dr. Prasanna. So Bade sir, please introduce Dr. Prasanna.
Hello. Hello, Dr. Prasanna.
Hello, sir.
Welcome to this session. As you all know, Prasanna is additional professor of anesthesia, soon to become a professor. He is specialized in neuro-anesthesia and is a very active member of the Indian Society of Neuro-anesthesia and Critical Care. I think soon he is likely to become a president of the ISNAC also, maybe in a couple of years.
Yes.
And he has tremendous interest in the neuro-anesthesia management. We had seen how he had done a lot of neuro-anesthesia cases, awake anesthesia, non-awake anesthesia, and all. And another interest which is a little common with me, Ranjan and Prasanna is first play badminton. So you don't go by the size of Dr. Prasanna.
Sir, he is doing cycling also nowadays.
But he plays
25 kilometers, 50 kilometers cycling also.
Yeah, but he plays quite well. And he had challenged me actually. I'm just waiting for that when we will have a match. So over to Dr. Prasanna to talk about today's topic.
Yes. Nagalakshmi, stop sharing the screen. You can
sir. Sure, sir.
Prasanna, please.
Yeah, can I share the screen now?
Yes, yes.
Sir, please, sir. Please, sir.
Are you able to see my screen?
Yes, yes, Prasanna. Full screen we can.
Yeah.
Yes, Prasanna, go ahead.
Yeah. Thank you, sir. Thank you, Bade sir, for the introduction and all your blessings. We are here this day is all because of your encouragement and blessings. Thank you, Dr. Ranjan and Nagalakshmi, for having me here. So all these days, so we will discuss brain monitoring in the perioperative period. All these days, I was thinking brain is a very complex but vital organ. And after listening to TRR sir and Raj, I thought brain is rather simple to manage as compared to the other organs. So why it becomes so vital? Because it is enclosed in a rigid box and there is no scope for expansion and there is a least scope for chopping it off also, like how we were discussing the lung resection. If you chop off some part of the brain, then some organs are not going to work. That's how it is. So to make the things worse, brain has no energy stores. So it is entirely dependent on continuous supply of oxygen and the other resources to it for its metabolism. That is the reason you get unconsciousness within seconds once the blood supply is cut off. And the permanent damage happens in minutes. So as compared to other organs, you have to act as fast as possible. That is why the term brain code has been coined to act it fast as early as possible. When we are monitoring the preoperative, intraoperative, and perioperative patients for that matter. So when I look at this screen of my monitor, I'll be very happy. What are all grossly I'll be monitoring? The heart rate and the blood pressure, end-tidal carbon dioxide concentration to be in the physiological range. I will monitor for any ECG changes. That's what I'm too much concerned about, particularly in patients who are at risk of cardiac ischemias. And I will monitor the temperature. So as long as I keep all these things in a physiological range, I'm quite happy with the patient and I'm not too much worried when I am treating in such, not with the patients with neurological injury. So now, along with this, what do I else monitor? So I do monitor for the airway pressures, for the pressure volume loops, and the FiO2 and all the other things being delivered. In addition, for the metabolic, I do monitor the pH, the oxygenation, and preoperative period in the OT or in the ICU. So now the usual scenario, what I said, am I satisfied when there is no neurological injury? Am I satisfied? But when it comes to the neurological or neurosurgical patients who are neurologically ill, what do I else monitor in addition to this is the Glasgow Coma Scale. In the clinical, what is most commonly used is a Glasgow Coma Scale. In the motor response makes the most of the important contribution to the prognostication. As long as I say the patient is M6, we are in a quite safer range. So when we are clinically monitoring the patient, we do look for this also as a surrogate marker of the brain. But when we know that there is excessive ICP increase and we want to sedate and paralyze the patient, or we want to deeply sedate him, we know that all this clinical monitoring becomes useless because it is very difficult now to determine the neurological status of the patient. Now consider these two cases. This is a patient with a big meningioma with a subfalcine herniation and a gross cerebral edema. And this is a patient you can see with a raised intracranial pressure, a decompressive craniectomy has been done, and there is a loss of white matter differentiation. Now consider this patient. These are the patients who are at high risk of raised intracranial pressure. Why do I am so much? The brain is dependent on the cerebral perfusion, what is coming to it, because there is no oxygen or glucose stores in the brain. So as we all know that the cerebral perfusion pressure mainly dependent on two factors, the mean arterial pressure and the intracranial pressure. So considering a normal patient with a mean arterial pressure of 90 and a intracranial pressure of 10, I know that I am in a good CPP range. But the scans, what I showed, there can be a ICP of 40 or 50, thus reducing the overall pressure. That means here, if I am not monitoring the brain separately, then I may be inducing ischemia in this group of patients because the cerebral perfusion pressure now is grossly abnormal, which is less than 60 millimeters of mercury. That is the reason there is, in the last 2 to 3 decades, there is a paradigm shift in the clinical and systemic monitoring to a brain-specific monitoring. In addition to clinical and systemic monitoring, we do brain-specific monitoring. So when we look at brain-specific monitoring, we are essentially
stay in the wait list for a long time. So the wait list mortality increases if they don't get an appropriate disease donor. And if they have an appropriate living donor, they can opt for living donor liver transplantation. The anatomy of liver is such that the liver can be divided into 8 lobules, and each lobule is drained specifically with a separate portal vein, hepatic artery, and bile duct. And again, all these 8 segments drain into the inferior vena cava separately through a hepatic vein. So it is possible to segregate each segment of the liver, and this has facilitated the living donor liver transplantation, where a partial right or left lobe is transplanted into the recipient from a living donor. So coming to the preoperative evaluation for liver transplantation. So we have seen this picture in the literature in our medical school, where a patient with liver disease presents with gynecomastia, ascites, and severe malnutrition, Dupuytren's contracture, etc. So going into a deeper perspective of the pathophysiology of cirrhosis to understand the liver transplantation physiology, the portal vein circulation shown here, it drains the entire GIT through the splenic vein, the superior mesenteric vein, and the inferior mesenteric vein. And this portal flow goes into the liver, and the outflow is through the hepatic vein into the inferior vena cava. So when cirrhosis sets in, there is increased resistance to portal venous blood flow into the liver, and this leads to severe portal hypertension. And this portal hypertension leads to the formation of collaterals from the portal to the systemic circulation through the formation of varices, which are present over the esophagus, rectal, and other sites, which can lead to increased variceal bleeding in patients with liver disease. That is, when there is severe portal hypertension due to the underlying cirrhosis of the liver, The body tries to compensate for this severe portal hypertension by producing nitric oxide and other vasodilators from the portal vein circulation and its tributaries. This increased nitric oxide production from the portal vein tributaries leads to splanchnic vasodilatation and pooling of blood from the peripheral volume into the splanchnic circulation. This leads to an pseudo-peripheral limb hypovolemia, and this pseudo-hypovolemia can lead to activation of baroreceptors and the renin-angiotensin system. This renin-angiotensin system leads to increased sodium and water reabsorption, which will finally again increase the central blood volume, but this blood volume is again accumulated into the splanchnic circulation and can lead to edema and ascites. So nitric oxide hyperproduction from the portal circulation being the central reason for the pathophysiology behind the organ effects in the cirrhosis. So when there is increased nitric oxide production and spilling into the systemic circulation, this nitric oxide leads to lower mean arterial pressure, low SVR, that is the SVR remains around 700 to 800 times second in these patients. This low SVR leads to high cardiac output, and again the nitric oxide effect leads to decreased vasopressor reactivity in these patients. And when the patients with liver disease get admitted to the ICU or come for the liver transplant, they exhibit false positive fluid responsiveness with low BP. And when fluids are given to these patients, they accumulate in the splanchnic circulation, again leading to increased ascites rather than helping in the peripheral perfusion. Again, these patients can have cirrhotic cardiomyopathy itself or the underlying disease like alcoholic cardiomyopathy. And previously, these patients were thought of having a decreased incidence of coronary artery disease because bilirubin was believed to be an antioxidant, and in such population, coronary artery disease was reported less compared to the general population. But recently, increased incidence of non-alcoholic fatty liver disease and alcoholic liver disease has led to an increased prevalence of coronary artery disease in patients with cirrhosis compared to the general population. So preoperative evaluation, we get a proper history regarding the patient's liver disease, progression of the liver disease, and the decompensations he had in the previous years, hospital and ICU admissions for various reasons like sepsis or acute kidney injury or ascitic tapping, and his exercise tolerance also. Along with it, we go for investigations according to each organ system. We get a screening 2D echo for all these patients to see for the ejection fraction and the right ventricular systolic pressure and the other valvular abnormalities. And based upon the number of risk factors for coronary artery disease, we decide whether to do a dopamine stress echo or a coronary angiography. If the patient is bedridden or admitted to the ICU or intubated, we get a CT coronary angiography if there is strong suspicion of coronary artery disease. Coming to the respiratory system, these patients, almost 50 to 60% of patients with chronic liver disease have right-sided hepatic hydrothorax. And this hydrothorax is nothing but the ascites which leaks into the pleural cavity through gaps in the diaphragm. So unless the patient develops respiratory distress due to hydrothorax, we don't usually tap this hydrothorax before the transplant. The second common presentation which we can see in the respiratory system is hepatopulmonary syndrome. Hepatopulmonary syndrome, the patient presents with severe refractory hypoxia. We do a screening pulse oximetry when we see the patient before the liver transplant. And if the SpO2 is less than 96% on air, we get a blood gas done to see for the PO2 on air. And if this PO2 is less than 80 millimeters of mercury, we again ask for a bubble contrast echocardiography to look for intravascular shunts in the pulmonary circulation. The pathology behind this hepatopulmonary syndrome is again increased nitric oxide expression, and this nitric oxide, which again acts over the pulmonary capillaries, vasodilates the pulmonary capillaries, and there is a particular specific diameter which is required for oxygenation to be effectively present in the pulmonary vasculature. And when this diameter is not present, oxygenation is impaired, and this patient presents with severe hypoxia, which is actually resistant to oxygen therapy also. So such patients, we actually intubate them if needed and put them on tracheostomy and take to liver transplant with PO2, acceptable PO2 of 40 to 50, and sometimes place them on ECMO therapy and then take to liver transplant on ECMO therapy. The third presentation in the respiratory system is the portopulmonary hypertension. This is exactly opposite to the hepatopulmonary syndrome pathophysiology. That is, instead of an increased nitric oxide expression in the pulmonary vasculature, there is increased expression of endothelin receptors and endothelin in the pulmonary vasculature in patients with portal hypertension. And this endothelins and other toxins are believed to originate from the cirrhotic liver, which acts upon the liver, which acts upon the pulmonary vasculature, leading to portopulmonary hypertension. So screening 2D echo, again, when the right ventricular systolic pressure is greater than 50 millimeters of mercury, we go for a right heart catheterization for this patient. And if the mean pulmonary artery pressure is more than 25 millimeters of mercury and the pulmonary vascular resistance is greater than 240, we place the patient on diuretics and pulmonary vasodilators. And this is considered a contraindication for a relative contraindication for liver transplant. And again, after proper therapy for the pulmonary hypertension, the patient undergoes a right heart catheterization to see for the mean pulmonary artery pressure. And if there is a good exercise tolerance with pulmonary artery pressure between 25 to 35, the patient is considered for liver transplantation under high risk criteria. Coming to the renal manifestations, again, the nitric oxide hyperproduction and the hyperactive renin-angiotensin-aldosterone system leads to increased angiotensin production, and this increased angiotensin causes a functional renal vasoconstriction, leading to hepatorenal syndrome. Hepatorenal syndrome behaves like a pre-renal type of renal failure, where these patients with liver disease get admitted with decreased urine output, widespread peripheral edema, and metabolic acidosis. And the treatment is terlipressin plus albumin therapy and tapping of ascites in these patients. And if the patient responds to terlipressin therapy, the mortality decreases in these patients. But in case if they don't respond to terlipressin therapy, the patient has to be taken for an emergency liver transplant, or the 3-month mortality reaches almost 100% in patients with hepatorenal syndrome. Again, hyperactive renin-angiotensin system leads to hyperaldosteronism, leading to sodium retention and ascites in these patients. The hyperactive RAS system also increases the increased expression of vasopressin receptors and vasopressin levels in these patients, which leads to water retention. And an imbalance between the aldosterone activity and the vasopressin activity leads to dilutional hyponatremia in these patients. So many patients who present for liver transplant have a sodium value less than 120 and even less than 110. Some centers consider sodium values less than 120 as a contraindication for liver transplant. But in case of emergency liver transplant, we have taken recipients with even sodium values of 114 to 115. And see to that the sodium values do not fluctuate above 6 to 8 milliequivalents during the surgery, so that they don't end up with central pontine demyelination after the liver transplant. So other confounding factors which are present in assessing the renal system is a falsely low urea and creatinine levels due to underproduction and sarcopenia in patients with cirrhosis. Diuretic-induced AKA and hepatorenal syndrome can be present at the time of evaluation. Such patients have to be admitted in the hospital and appropriate treatment done to evaluate the kidney dysfunction and see for a resolving acute kidney injury. So since the creatinine values do not reflect the kidney, do a 24-hour urinary creatinine clearance to get an estimated GFR, serum electrolytes to look for hyponatremia, hypokalemia, either diuretic-induced or dilution hyponatremia, urinary sodium to differentiate between hepatorenal syndrome and an intrinsic renal failure, and appropriate therapy like terlipressin albumin therapy. If the patient does not respond to terlipressin albumin therapy, renal replacement therapy is initiated before the transplant, and the patient is considered for a simultaneous liver kidney or a sequential liver kidney transplant according to the necessity of dialysis before the transplant. These patients again get infected in the ascitic fluid, leading to spontaneous bacterial peritonitis, where a diagnostic ascitic tap can reveal increased ascitic fluid cell count, and appropriate antibiotics has to be initiated before the transplant. The fifth system, the coagulopathy which exists in patients with liver disease. We know the INR values and the platelets are low. INR is high and platelets are low in patients with cirrhosis. Still, these patients undergo many invasive procedures without any dangerous bleeding. It was due to actually rebalance the hemostasis in patients with cirrhosis. That is, many factors are produced from many coagulation factors which are responsible for primary, secondary hemostasis, and fibrinolysis are produced from liver. But there are only certain factors which are produced from the vascular endothelium, like von Willebrand factor, which is the levels of which are very high in patients with cirrhosis, to compensate for the decreased coagulation factors produced from the liver. Again, as I said, there are low procoagulant factors, but again, at the same time, there are anticoagulant factors like protein C and protein S, which are also produced from the liver, and these factor levels are also reduced, which again balance with the low procoagulant factors due to liver disease. And again, the fibrinolysis is also balanced due to decreased antiplasmin as well as plasminogen, which are both secreted from the liver. So, assessment of coagulopathy in patients with liver disease is not complete with only INR or platelet count, and further point of coagulation tests like thromboelastography and the ROTEM is required to actually assess the coagulopathy and replace appropriate. Other systemic effects, there can be persistent hepatic encephalopathy in these patients at the time of liver transplantation. Blood ammonia levels are done to see for the hepatic encephalopathy, and other precipitating factors of hepatic encephalopathy should be ruled out before transplant. And extrapyramidal disorders can be an extreme spectrum of hepatic encephalopathy. An MRI brain is advised before liver transplant to look for other causes of extrapyramidal disorders if the patient presents with Parkinsonism. There is a relative hypothyroidism in patients with the liver disease. That is, there is a normal secretion of T3, T4, and TSH, but there is increased reverse T3 levels in these patients with CLD, which puts them into a relative hypothyroid state. And there is increased susceptibility to infections also. So cultures are sent before the liver transplant if there is history of sepsis or GNP sepsis in these patients before coming for liver transplant. The other effects of portal hypertension like hypersplenism, which leads to anemia, leukopenia, and thrombocytopenia. We don't transfuse unless the hemoglobin levels come less than 6 gram deciliter. Leukopenia, when the absolute neutrophil count is less than 1000, then the patients are considered for fulgrastim and the bone marrow evaluation also to actually see for the look at the reason for leukopenia. Thrombocytopenia, unless the patient undergoes an invasive procedure, platelet counts of 10,000 are also acceptable and are taken to liver transplant, and tech-based correction done during the liver transplant. Malnutrition and BMI and severe sarcopenia are some important factors which actually predict the post-transplant outcome. Patients with malnutrition and severe sarcopenia, which is seen with Swartz muscle index in the CT abdomen, can actually predict the post-transplant outcome and the need for prolonged mechanical ventilation. So portal hypertension being the primary cause for all the pathophysiology behind patients with cirrhosis, this table can be interpreted, that is HVPG. HVPG is the method by which we measure the portal pressure in these patients with cirrhosis, and HVPG reflects the portal pressure. When it is 6 millimeters of mercury, there are no complications, and when it is doubled to 12 millimeters of mercury, all these patients are at increased risk of variceal bleeding, ending up with encephalopathy, and more than 16 millimeters of mercury, the mortality is 60 to 100%, and the patient can present with all type of decompensation seen in liver disease. So when do we transplant a patient with a stable liver disease? So all liver cirrhotic patients present to the OPD with various decompensation, and these patients are assessed using these scores, that is the MELD score and the MELD sodium score. The MELD score involves creatinine, bilirubin, and INR at that particular point of time. This MELD score ranges between 6 to 40. And when the MELD score lies below 15, these patients are not considered a candidate for liver transplant because the liver transplant itself poses a significant risk for their mortality and morbidity after the surgery. Once the MELD score increases more than 15, the patients are considered candidates for liver transplant because their 3-month mortality is very high when the MELD score increases more than 15. Now, recently, the sodium values have been incorporated into these MELD score because hyponatremia is again found to be an important factor which actually predicts the post-liver transplant outcome. So, contraindications for liver transplant, the patient coming for liver transplant can never be completely fit for anesthesia and surgery. Again, the systemic conditions are optimized, and there are certain absolute contraindications for liver transplant, like uncontrolled sepsis with vasopressor requirement, metastatic carcinoma involving other
The loss is oh
yeah.
Yeah, I think he's back.
Still it is low.
Is it mute or?
Hello, Nanda?
No, I think there's some internet problems for.
Yeah, okay.
Yeah.
We will get back to him after that. Can we move on to the next one?
Yeah, fine.
Manik?
Yeah, sure.
Manik?
Yeah, can you hear me?
Yes, Manik. Please introduce the next speaker.
Sure. Good evening, everybody. Thank you, ISA Puducherry, Dr. Ranjan, Dr. Nalashmi, for giving me this opportunity to be a part of this academic program. It's my pleasure and honor to invite Dr. Arun Kumar Arumugam. He's a consultant cardiac anesthetist at SIMS Hospital, Chennai. He's also a fellow of the Indian Association of Cardiovascular and Thoracic Anesthetists. He's got around 11 publications in the national and international journals. His areas of interest include anesthesia for complex aortic surgeries, perioperative echocardiography, TE, and also ECMO. He's going to talk on spinal cord protection during aneurysmal surgeries. Welcome, sir.
Thank you, sir. First of all, I would like to thank the ISA Puducherry President Dr. Ranjan and Secretary Dr. Nagalakshmi for giving me this opportunity to present in this conference. So my topic for today is spinal cord protection in aneurysmal surgeries. I'll be mostly concentrating on the thoracoabdominal aneurysms. So before going on to the subject, I'll just briefly introduce about the topic and blood supply to spinal cord, the pathophysiology of spinal cord injuries during the open repair of thoracoabdominal aneurysms, monitoring and prevention, and how do we intraoperatively manage such problems while doing the aneurysmal repair. So it is the dilatation of the aorta that causes aneurysms, and it can be either ascending aorta, arch, descending thoracic aorta, abdominal aorta. So thoracoabdominal aneurysms, it is a continuous dilatation of the descending thoracic aorta extending up to the bifurcation of the aorta at the abdominal level. So usually the older patients, they present with aneurysm because of the degenerative disease, especially atherosclerosis, and younger age group patients who are mostly have connective tissue disorders such as Marfan syndromes, Ehlers-Danlos, or they might have an aorta arthritis, which in later stage can produce aneurysmal dilatation of the aorta. So recent years, the aneurysm incidence has been rising because of the effective imaging and screening of patients and due to the aging of the population in the worldwide. So Crawford initially classified the thoracoabdominal aneurysms into 4 types. So as you can see in this picture, the type 1 aneurysm extends from the supposed subclavian artery till the suprarenal part of the abdominal aorta, and type 2 aneurysms extends from the subclavian artery till the bifurcation of the aorta. And type 3 aneurysms, that is the aneurysms you can see in the distal part of the descending thoracic aorta and extending up to the bifurcation of the abdominal aorta. And type 4 is just the abdominal aorta that is involved. So the open repair of thoracoabdominal aneurysms has many complications, especially bleeding and stroke and spinal cord ischemia, which is the deadliest complication that occurs during the open repair of any thoracoabdominal aneurysm repair. So as you can see in this picture, the type 2 and type 3 carries a higher risk of spinal cord injury, especially in the earlier days where the risk of spinal cord injury is about 33% in type 2 and 13% in type 3. But recent years, there is an improvement of the surgical techniques and intraoperative monitoring and intraoperative management. The type 2 incidence of spinal cord ischemia in type 2 has come down from 33% to 6.3%, and type 3 there is about 2.6%. So we all know spinal cord is perfused by 2 posterior spinal arteries and a single anterior spinal artery. The 2 posterior spinal arteries is a branch from the posterior inferior cerebellar artery, and the anterior cerebellar artery is the confluence of the both vertebral arteries. So apart from these 2, that is the anterior cerebellar artery almost supplying the anterior 2/3 of the spinal cord, and the posterior spinal artery supplying the posterior 1/3. Apart from this 2 main arteries, so we have almost 31 pairs of radicular arteries anteriorly as well as posteriorly. So these radicular arteries, along with the spinal arteries, perfuse the spinal cord from cervical level to the lumbar region. So we have 4 territories in the spinal cord. As you can see in this slide, there is supraaortic, that is the cervical arteries, especially the costocervical trunk, that is the subclavian artery, which is the branch of the subclavian artery. So this plays an important role in the spinal cord perfusion as well. And the thoracic aorta, that is supplied by the thoracic part of the spinal cord, it is supplied by the intercostal arteries, and the abdominal part is by the lumbar arteries. The pelvic region in the internal iliac arteries and the iliohypogastric arteries. That also plays a major role in providing perfusion to the spinal cord. So the studies have shown that any 2 of these territories is compromised during the surgery of aneurysms, then there is a risk of spinal cord ischemia, which will present as paraplegia or paraparesis in the postoperative period. So apart from these arteries, that is the artery of Adam-Queis, that is the arteria radicularis magna, which arises at the level of T9 to T2. This is a significant artery because this supplies the lower part of the thoracic aorta and the upper lumbar region of the thoracic aorta. And this forms a hairpin lobe, as you can see, forms along the course of the anterior spinal artery. So this part of the region where the artery of Adam-Queis joins with the anterior spinal artery forms the high threshold for spinal cord ischemia because of the opposing blood flow that is present in this region at the lower thoracic and the upper lumbar region of the spinal cord. So apart from the major blood supplies, especially with the anterior spinal and the posterior, the recent studies have shown there is a rich, dense network of paraspinal musculature as well as the various blood vessels arcading in the spinal canal. As you can see, there is arcading of vessels in the epidural space in the intraspinal canal region. As there is in the brain, we have a circle of Willis. Similar to that, we have an arcade of vessels in the spinal canal, which nourishes and replenishes the blood supply to the spinal cord. So apart from when there is a compromise in the spinal cord perfusion by either of the arteries or radicular arteries, this can also provide perfusion to the spinal cord. So that can thereby preventing the spinal cord injury in the postoperative period. So moving on to the pathophysiology, how does a spinal cord injury occurs during open repair of aneurysm? It is the most the risk factors, the 3 independent risk factors that is seen is Crawford type 2, which carries the most highest risk of having a spinal cord ischemia. Emergency, which has 26% of patients can land up with spinal cord ischemia, and elective surgery is just 12%. So again, the open repair versus endovascular repair. Open repair carries a more risk when compared to the endovascular repair. Endovascular repair is just 1 to 6% of the patient may land up with paraplegia. So apart from the risk factors, we have a predisposing factor for spinal cord ischemia. So as you can see, there are other associated problems when the patient presents with aneurysm is a complicated aortic dissection along with an aneurysm. with a malperfusion. So the risk almost increases from 26 to 50%. So, and if a patient is having prior aortic intervention, such as he has undergone a upper thoracic region of the thoracic aorta has been replaced, and more segmental supply for the spinal cord has been sacrificed, and he comes for the second stage of the operation, then the risk again increases during the second time of the operation. So again, the duration of aortic cross clamp that determines the perioperative morbidity and the mortality for any cardiac surgery, and especially for open repair of aneurysmal surgeries. The duration of aortic clamp determines the risk factor for spinal cord ischemia. Acute anemia, as we know that oxygen carrying capacity is reduced, so thereby reducing the overall perfusion of the spinal cord in the acute anemic condition. Systemic vasodilation, vascular steal phenomenon that also can occur during the time of prolonged cross clamping and hypothermia, which I'll be explaining later. The main three factors that triggers spinal cord ischemia is the duration and the degree of ischemia, failure to re-establish the spinal cord blood flow, and a biochemical mediated reperfusion injury. So as you can see, when the blood flow is compromised to the spinal cord, then there is a risk. Apart from that, when there is a CSF pressure, when there is an increase in the CSF pressure, then the spinal cord ischemia, there is a compromise to the blood flow. And when the increased venous pressure also, there is a compromise in the spinal cord perfusion pressure. So spinal cord perfusion pressure is similar to cerebral perfusion pressure. It is the mean arterial pressure minus the CSF pressure. So when there is hypotension, so there is decreased spinal cord perfusion pressure, and thereby increasing the risk for spinal cord ischemia. So aortic cross clamp, that is the major determinant in the postoperative paraplegia. So when the cross clamp time increases from 15 minutes to almost more than 60 minutes, so the incidence of the spinal cord ischemia increases from almost 0% to almost 25 to 100% patient who can land up with postoperative paraplegia. So what happens in open repair? So if it is a short segment of spinal, the aneurysm that can be repaired, so it is just a single clamp will be applied to the proximal part of the aneurysm, so that there is hypertension proximal to the clamp. So what happens is there is a hyperperfusion of brain, so increased blood flow to the cerebrum, and thereby causes increased production of the CSF. So thereby increasing the CSF, increasing the spinal cord perfusion pressure. So that indirectly impairs the blood flow to the spinal cord. So this can be reduced with vasodilators, especially when there is hypertensive patient coming for a open repair surgeries. Apart from that, myocardial dysfunction, especially the diastolic dysfunction. So when there is a diastolic dysfunction or the patient is having a comorbidity with coronary artery disease, that can increases the central venous pressure, thereby increasing the CSF pressure, and which ultimately leads to decrease in the spinal cord perfusion pressure. So aortic cross clamp, the proximal part where you can see there is hyperperfusion and there is increased BP because of the increased afterload just proximal to the clamp, whereas the distal part there is no blood flow and there is less perfusion to the distal part. So to counter all these things, various surgical techniques and perfusion techniques have been deployed to reduce the level of ischemia. So which I'll be discussing in the coming slides. So apart from that, when there is a drop in the blood flow or perfusion, there is a direct cytotoxic reaction, and which can cause edema formation, which causes a spinal compartment-like syndrome, as we see in peripheral vascular diseases. So reperfusion injuries during rewarming that releases the free oxygen radicals that indirectly causes tissue damage. So these are the pathophysiology of spinal cord ischemia. So this is a steel phenomenon. Patient is shivering. There is increased blood flow to the muscles and thereby decreasing the blood flow to the. This usually happens in the postoperative period. So there is decreased blood supply to the spinal cord, where there is an increased blood supply to the shivering muscles. And during the intraoperative period, as I said, in the rewarming period, there is increased blood flow to the musculatures. So that by reducing the blood flow to the spinal cord. So, and for this is all for the open repairs. When there is an endovascular repair, what happens is the intercostal, that is the intercostal arteries are not plugged. So what happens, there is back bleeding inside the aneurysmal sac. So thereby there is more blood flowing into the aneurysmal sac, whereas less blood flow to the spinal cord, and thereby the increasing the risk for spinal cord ischemia. So how usually we monitor intraoperative for spinal cord ischemia? So my work has been simplified by Dr. Prasanna because he has already spoken about the evoked potentials. So similar to the brain function monitoring, so we have spinal cord function monitoring by somatosensory evoked potential and motor evoked potential. Various studies have proved when this evoked potential are used for thoracoabdominal aneurysms, especially with the motor evoked potentials. So somatosensory evoked potential, the latency to the stimulus. So if it is delayed, then there is the risk of spinal cord injury is more. And usually what happens in somatosensory evoked potential, it is only the posterior and the lateral column are assessed, and it has a low specificity. So, and the false positivity rate is almost 67% in when only somatosensory evoked potential is used. Whereas in motor evoked potential, the anterior column can also be assessed. It is highly specific, and the only drawback here is the anesthetic drugs can interfere when motor evoked potential is used. And for especially for thoracoabdominal aneurysms, we cannot give TIVA. So somatosensory plus the motor evoked potential can be a useful tool for predicting the postoperative paraplegia and paraparesis. Again, NIRS has been spoken before. So it is a non-invasive technique. So apart from the cerebral oxygen monitoring, NIRS is now can be used for the regional oxygen saturation of the tissue sample, especially with the spinal musculature. The spinal cord perfusion can be determined by the fall in the oxygen saturation. So as I said before, there is apart from the normal blood supply to the spinal arteries, especially, there is a rich vascular dense network of paraspinal vasculature. So that is assessed by the NIRS monitoring. So it is an easily applicable non-invasive tool for the continuous surveillance of the oxygenation of the spinal cord region, especially when MEP is combined with the NIRS, the sensitivity and the specificity increases to almost 100%. So this is the study which was conducted in and published in European Journal of Cardiothoracic Surgery, where 2 optodes of the NIRS were kept in the T3 region of the thoracic spine and at the level of T12. So the T3-T4 ratio of this NIRS signal is measured along with the MEP monitoring, and those patients who had an MEP signal for postoperative, the prediction of the signal latency signal. So there is a decrease in the perfusion of at the level of the thoracic level. So this plays an important role for spinal cord perfusion monitoring. So how do we prevent spinal cord injury apart from monitoring? So it is usually, as I said before, it is maintain the perfusion pressure, decrease the ischemic time, increase the tolerance to the ischemia. So how do we maintain the perfusion pressure is just to increase the perfusion pressure of spinal cord, either by increasing the mean arterial pressure or decreasing the cerebral spinal fluid pressure. To decrease the ischemic time, that is usually done by the surgical techniques, either by putting a shunt from the proximal to the distal or left heart bypass. And how do we increase the tolerance to ischemia? That is can be done by hypothermic circulatory arrest. So decrease the duration of ischemic time. It is the surgical techniques has been described. That is the single clamp technique and sequential aortic clamping technique and staged operation. So the Crawford inlay. So the surgical techniques here, you can see the God shunt, that is the shunt is placed at the proximal part of the aorta and the distal part of the aorta. So there is blood flow to the distal part of the aorta. So there is no compromise in the blood flow to the spinal cord as well. So left heart bypass, it is similar to the God shunt, but it is connected from the left atrium to the left femoral artery. So reimplantation of segmental arteries, which is the most crucial part of open repair of abdominal thoracoabdominal aneurysms. So as you can see here, the intercostal arteries at the level of T8 to T12, where the artery of Adam-Quees rise, because it is not visualized through the naked eyes. But since we know roughly it is around the T9 to T12. So what we do is usually make a patch of the native aorta onto the graft, Dacron graft. So the blood supply at the level of T9 to T12 is maintained. And so this is the only patch that was reimplanted in this case. So other thing is reduce the ischemic, increase the tolerance to the ischemia. So how do we do it is hypothermic circulatory arrest. So usually we do hypothermic circulatory arrest to reduce the oxygen demand and thereby preventing the ischemic. We can prolong the ischemic time as well. So for young patients, usually we use deep hypothermic circulatory arrest, where the temperature is brought down to almost less than 20 degrees centigrade. And for patients with older and comorbidities, it is moderate hypothermia, because the effects of hypothermia itself can cause other problems such as bleeding and coagulopathy. Regional cooling, that is the ice cold saline is pushed into the spinal canal, that is and withdrawn 100 ml liquids like that. But it's just a few studies have shown that it has improved the spinal cord perfusion. It has reduced the spinal cord injury. The major part of my presentation is that the CSF drainage, where as an anesthetist, we can intervene in the surgery such as for the open repairs of aneurysms. So when do you do a CSF drainage? So indication for CSF drainage is when the anticipated endograft coverage is up to the level of T9 to T12. When the thoracic aortic coverage of more than 20 centimeter, then the indication for CSF drainage is warranted. And again, the symptomatic spinal cord injury in the postoperative period. So intraoperative period, if suppose we missed out, and postoperative period, if the patient develops paraparesis, when we can do a CSF drainage in the postoperative period. If there is compromised collateral pathways, extensive aneurysmal diseases like type 1 and type 2 Crawford classification. So these are the indication for CSF drainage. So how we do it is like normal epidural puncture at the level of L2 to L3 or L3 to L4 intervertebral space. We pass the Tuohy needle until the spine intrathecal space till we get the CSF. So that is connected to the transducer system. This is the arterial system. This is the central venous pressure system, and this is the CSF monitoring. Especially we should take care when the CSF is connected not to the heparinized saline. It should be separate from the arterial and the central venous pressure monitoring system. So it is the epidural or the celastic catheter is passed via the epidural needle at the L3 and L4 space, and usually 5 to 10 centimeter is placed inside the subarachnoid space, and it is usually connected to the closed circuit reservoir. Pressure is maintained at the transducer is maintained at the level of midline of the brain or the right atrium. The target CSF pressure should be less than 10 millimeter of mercury. And the CSF can be drained intermittently or continuously, but not more than 10 ml per hour. The catheter can be removed within 72 hours of the postoperative period. So this is an automatic pressure-driven CSF drainage system, LecoGuard, which senses the CSF pressure if it is more than 15 mm of mercury, or you can set the target pressure, and then it automatically brings down the pressure by draining the CSF fluid 10 ml accordingly. So we usually follow a rule of 10, that is the epidural catheter is placed into the subarachnoid space at 10 centimeter from the skin level. Maintain a pressure of less than 10 millimeter of mercury. And aliquots of 10 ml per hour can be withdrawn intermittently, because if the more amount of CSF is withdrawn, then there is a risk of tearing of the bridging veins. Apart from the CSF drainage, the neuroprotective agents also plays an important role in preventing spinal cord injury, especially with methylprednisolone. Other drugs such as carbamazepine, magnesium, volatile anesthetics, intrathecal papaverine has shown some good results. Naloxone, though it has shown some good results, but doesn't have much effect on the spinal cord protection. Other drugs are lidocaine, barbiturates, and mannitol. IV methylprednisolone, as I said, that is one of the oldest and the most commonly used IV agent. There's 30 mg per kg body weight over 10 minutes is prior to aortic cross clamp it is given. It inhibits the neuronal cells, attenuates the apoptotic neuronal death. So this is an article shows the role of intrathecal papaverine, where the permanent paraplegia was reduced in when the intrathecal papaverine was given, about from almost 3.6% to 1.6%. The other thing is COPS protocol, where for the anesthetist to maintain the perfusion pressure. One is the CSF drain status. That is malfunction, replace the drain. If it is normal, make the patient flat, drain the pressure if it is more than 15 millimeter of mercury, and drain for 7 days it is written, but we usually take it for 72 hours. Oxygen delivery, if it is low, just maintain the oxygen saturation. Hemoglobin should be more than 12 milligram per deciliter, and maintain a cardiac index of more than 2.5 liter per minute body surface area. The mean arterial blood pressure should be more than 90 millimeter of mercury. The spinal cord perfusion pressure, that is, should be more than 80 millimeter of mercury, and the cognitive status, check for the cognitive status if there is a bloody CSF. So we encountered a case in the recent 2-3 months before. So where a patient with a 41-year-old male presented with hoarseness of voice, presented where CT images showed ascending arch and descending thoracic and the abdominal. The whole aorta was involved and it is dilated. So at the first stage, we operated for ascending arch, and the descending thoracic aorta was replaced. So second stage, he might require an abdominal aorta replacement at the later stage. So in this, the patient was cooled to 22 degrees centigrade, and the total circulatory arrest, since it was ascending arch and the descending thoracic aorta, the total circulatory arrest time in this patient was 55 minutes, which is more than the prescribed limits. And the mean arterial pressure when we came off bypass was 55 millimeter of mercury, and the CSF pressure monitored was more than 20 millimeter of mercury. So in the intraoperative period itself, it showed that patient might land up with some paraparesis. As we predicted, the patient presented with paraparesis in the immediate postoperative period. Though he was given injection methylprednisolone, 1 gram was given during the pump from the paraparesis. These are the negative points that landed up as a trouble. So as you can see, this is the aneurysm of the thoracic aorta. So after induction, this is his pressure was 150/80. As you can see, this is the spinal cord, the CSF pressure, which is around 12 millimeter of mercury. Here, after coming off bypass, this is 75. We had to decrease the CSF pressure by reducing the CSF flow. So to summarize, for any prevention of spinal cord injury during the open repair of aneurysmal surgeries, we have to maintain a mean arterial pressure of more than 80 millimeter of mercury. CSF pressure should be less than 10 millimeter of mercury, and reimplantation of segmental arteries and neuroprotective agents can be beneficial. Thank you.
Thank you, Dr. Arun, for an interesting talk and sticking on to your time. We can take questions now. Dr. Nagalakshmi, any questions?
1 minute, sir. I'll just check.
So, Bade sir, you would like to say something, sir?
No, one question I thought.
Yes, sir.
Sugar monitoring was done intraoperatively, and what level of blood sugar? Because patient is on prednisolone. So do you monitor blood sugar and try to keep it at a particular level? Because spinal also can occur.
Yeah.
Hyperglycemia.
Yes, sir. So we monitor the sugar levels because we take almost every hourly ABGs, and we monitor we usually keep it around less than 200. And if it is increases more than 200, and we give insulin in the pump.
200 is pretty high, no?
Pretty high, but yeah.
For a normal patient, 200 blood sugar is pretty high.
200 is high, yeah. But our protocol is not to intervene less than 2.
What basis is there for this protocol? No, for this basis, some protocol. What is the basis of this protocol? Because 200 anyhow, I think it looks pretty high. A normal patient.
Usually we keep between 150 to 180.
Yeah, 180. Yeah.
Anything more than 180, whether it's a diabetic or non-diabetic, we start them on insulin. No, sir, but I said, what is
yeah. Because definitely we won't like to have a 200 when you are working on the spine.
Yes.
Okay,
thank you, sir. Thank you so much. Dr. Lenin, would you like to add?
Yeah, Dr. Nanda is here. So should we...
Nanda, can you summarize? Nanda, you're there?
Yeah. I think I could see somebody said Nanda.
Yeah, I'm here, sir. I'm here, sir.
Nanda, can you just summarize the talk on 1 minute? Just a summarize of what you talked.
Should I project the PPT, sir? Or?
No, directly you can talk.
Okay, sir.
Or else, is there any interesting questions there? You can answer the question.
Yes, sir. Yes, sir. I think to summarize,
difficult talk to summarize there within.
Yes, sir.
It's very difficult.
I think we are giving him the least time. He has much more to do.
No, that's okay.
We are giving the least time.
No, it's okay, sir. Because my email was also bad. I don't know what.
Yeah. Would you like to have your PowerPoint and summarize? It's okay, fine.
No, sir. I can take questions, sir. If okay.
Not many questions have come.
Oh, okay, fine. Your mic is muted, Nagalakshmi.
Yeah.
Hello.
Ananda. Ananda, tell me, you can continue.
Okay, sir. Should I summarize, sir?
Yeah.
Okay, sir. So there is no particular anesthetic technique which has proven superior in liver transplant. And again, the recipients, they are never completely optimized before a liver transplant. So the only thing we can do is see to that they don't have any signs of sepsis and their cardiovascular status is optimized. And then intraoperatively, the coagulation monitoring blood products are transfused based on the TEG rather than INR or platelet count. And there are various phases of liver transplant: dissection, the anapatic phase, and the reperfusion phase. So each phase has its own hemodynamic insults, and we try to limit the acidosis or the new graft. So other thing, reperfusion syndrome, where the patient can end up with ventricular tachycardia and cardiac arrest also due to severe potassium as well as other toxins which are released from the new graft. That is a very stressful part of the liver transplant where appropriate measures have to be taken immediately to prevent severe hypotension as well as ventricular arrhythmias. There are case scenarios where we have to start on ECMO after the reperfusion. And this is the multiple period for even pulmonary CR, good urine output, and maintained blood glucose levels without any ischemia is a sign of the graft functioning. Our post-operative concerns or to prevent organ rejection, start immunosuppression. The after effects of massive transfusion and hemodynamic fluctuations like acute kidney disease should be managed. Pulmonary edema trial should be after. And Doppler is done every day till POD5 to look for hepatic artery and port graft dysfunction where there can be many precipitating factors. Plasmapheresis or pulse steroid therapy in the post period. Any discussion on liver transplant cannot be finished without honoring Professor Thomas Stahl, who's pioneering opportunity.
Very nicely, but unfortunately, for cardiovascular monitoring.
Cases.
Ask the question there.
Yeah, but
can you highlight about reperfusion injury in transplant patients? Sir had put it in the chat box.
Okay. Reperfusion syndrome in liver transplant patients. The reperfusion syndrome can be decreases less than 50 to 40 minutes within even 2 minutes of. And this with various electrolyte of disease like hypocalcemia and extended urine also. So the literature at present has not extensively defined the reperfusion syndrome, but most of the complications seem to happen during the reperfusion syndrome. And even though the tech parameters show a hypocoagulable state after the reperfusion, but there are literature which shows there is increased incidence of pulmonary artery thrombosis after the reperfusion syndrome. And again, the pulmonary vascular resistance increases immediately after the reperfusion, which can lead to severe right ventricular dysfunction or right heart failure, which may necessitate an ECMO initiation immediately after the reperfusion.
Do you use any technique or any method to reduce this reperfusion injuries?
No, sir. We actually look at the hemodynamic behavior of the patient during the dissection and the anaphylaxis phase, and accordingly we decide what to give during. And usually we give boluses of adrenaline, either 10 micrograms or 100 ounces of the reperfusion before 5 minutes, and we give boluses of adrenaline. Some practice giving bicarbonate to neutralize the acidotic